Hello, this teaching video is on tooth extraction and placement of an implant without a cone beam. Many of you live in parts of the United States or different places in the world and don't have access to a cone beam. So in my opinion, the technique I'm going to show you is as accurate as placing an implant with a cone beam. This is a before and after. I'm extracting this lower left first molar. It's taken in a mirror, so it looks like the lower right side, but it's actually the lower left, number 19. And this is the final implant. Here's the implant in place with the crown. It's a screw retained crown. We're going to talk about extraction of the tooth, grafting the socket, how long to wait, and then how to place the screw retained crown. This is local anesthesia. I can't stress enough, and again, in my opinion, how important it is to be able to provide painless and profound local anesthesia. So you can watch that video, and there's another one on maxillary anesthesia, local anesthesia. Now, I've took out a wisdom tooth back here, so you see some bleeding. One of the important things when you're extracting a tooth, especially if you're planning on placing an implant, is you maintain the facial bone and the lingual bone or the palatal bone. So I want to remove this tooth in pieces. I don't want to lose the buccal bone or the facial bone when I extract the tooth, because I need that bone to form a cup for the bone graft. We'll talk about bone grafting here in just a minute once I extract the tooth. So you'll remember there's distal roots and then two mesial roots. Sometimes there's two distal roots, so I want to section the tooth between the mesial and the distal roots. I want to be sure to go past the furcation. You're not really worrying about damaging the inferior alveolar nerve because you're not sectioning near that apically into the tooth. So I'm not removing any buccal bone. When you saw me going around the facial with that round burr, I'm actually cutting into the tooth on the facial to create a little space. But I'm not removing any facial bone or any lingual bone. So I'm trying to elevate the mesial half of the tooth, just rolling that tooth with this elevator. Now I've got a mesial space to elevate the distal half of the tooth into, and you just roll it with elevators. You always need some space to elevate a tooth or a root fragment into. There's the piece. Be sure you protect the airway. You don't want the patient to aspirate the piece of the tooth. Also, if there's amalgam fillings or things like that. Now let's talk about grafting the socket. I love platelet-rich fibrin. But to gain platelet-rich fibrin, the patient's got to have some veins in the antecubital fossa. You don't want to, because you've got to draw blood and spin it down. You really can't do that if they're just small veins, like hand veins. But some patients just don't have good veins, and you can't, it's very difficult to draw blood and then spin it down into platelet-rich fibrin. In this case, the patient didn't have very good veins. I used a hand vein for the IV sedation, but you can't draw blood from small veins. So I'm using cortical bone, freeze-dried bone, Maxius. Wet the freeze-dried bone with distilled sterile water and then pack it into the extraction site and place either a slab of platelet-rich fibrin or resorbable collagen membrane over the grafted extraction site. And I'll show you how this works. You can watch my videos. See, here's the resorbable collagen membrane. Suturing with 3/0 plain gut suture. This suture will resorb in 4 to 7 days, and that's plenty of time for the flaps to adhere to the bone, to the alveolar process. And since I haven't reflected a big flap, only the coronal parts of the flap are having to adhere. I don't have a reflected flap down to the unattached or non-keratinized gingiva. So I normally place 3 sutures in a situation like this. Now here's the secret of suturing. You go 1, 2, 3 away from you, pull, then go 1 wrap towards you, pull, and then another one away from you, pull. Now if you go 1, 2, 3 away from you for the first pull, that will stay snug while you're doing the wrap towards you. If you just do 2 wraps, 1, 2, and pull, oftentimes that wrap will loosen a little bit before you get to the second single wrap towards you. There's the graft. Now this is 8 months later. You can see how the flaps have closed. It heals about 1 millimeter a day and it granulates in. But you don't have to reflect all the way down to the unattached non-keratinized gingiva and cut releasing incisions to bring that flap over. So this is after 8 months of healing. It normally takes that bone about 6 months to heal, but you'll be able to see the outline of the roots even longer than that. So I know I've got 15 millimeters to the apex of the roots. So I'm going to place an implant that's 12 or 14 millimeters. 12 is plenty. This technique you can use without a cone beam. I'm going to use a pilot drill with an endostop, local anesthesia. Then I'm wiping the surgical area with chlorhexidine. Then I'm going to dry it, and then I'm going to put a dot with a Sharpie marker right in the center. Now many times I'll use a surgical guide, but often if it's a single tooth, I won't, especially if it's in the posterior area. I'll just put a dot, and if the angulation of the adjacent teeth is correct, the roots, then I'll stay in line with the adjacent teeth and place my implant in that dot in the center of the area. Now this is the pilot drill with the rubber stop. So that measurement was 15.34. I'm measuring here about 17, but I'm going to move this stop and make the pilot drill about 14. Because you don't, what are you worried about when you place implants? Damaging the inferior alveolar nerve. If you read the articles that I have in the library of dentistrymasterclasses.com, there's no real issue with perforating the floor of the maxillary sinus. The problem with perforating the floor of the maxillary sinus is if the implant is in the sinus, it's not in bone, it's just in space. So you want the implant to be in bone. I'd like to have at least 5 or 6 millimeters of the implant in bone. There are some 6 millimeter large diameter implants you can use. Typically, the shortest implant is 8 millimeters. So I want at least 5 or 6 millimeters of the implant to be in bone. This is just talking about the maxillary area. Now in the mandible, you want to stay a couple of millimeters away from the inferior alveolar nerve. You don't want to take any chances on damaging the inferior alveolar nerve. So here's my rubber stop, here's my pilot drill, and I'm going to drill 14 millimeters. I want to stay a couple of millimeters away from the inferior alveolar nerve. If you take a periapical radiograph, that's a 1-to-1 ratio. You can see the rubber stop is on the gingival tissue. If this is 15 millimeters from the rubber stop to the tip of the pilot drill, you've got 2 millimeters of gingival tissue. So if this is 15, that means the part of the pilot drill in the bone is 13. So we had 15 millimeters of alveolar bone from the crest of the alveolar bone to the tip of the roots. That's where the nerve is. You may be able to see the inferior alveolar nerve in the radiograph, but the tip of the root is going to be basically the inferior alveolar nerve. So if it's 15 from here to the tip of the implant, from the bottom of the rubber stop to the tip of the implant, then you're going to be 13 millimeters in the bone, because we're giving 2 millimeters. See, here's the tip. We're still a good millimeter from the tip of the root, and so here's the alveolar crest, and the rubber stop is right here. So this is about 2 to 3 millimeters. And you can see my alignment is good. It's parallel approximately to the adjacent teeth. Now, I really like the dentist drills. I don't like their impression copings, and their implants are okay, but their drills are fabulous. And I don't know why every implant drill is not this way. They have shoulders on the drills at the length. So this shoulder is 14 millimeters from the tip of the drill, and the drills just get wider from 2.2 to 4.8. So these are 8 millimeter drills in length from the tip of the drill to the shoulder. 10, 12, 14 millimeters in length from the tip of the drill to the shoulder, and then the drills just get wider. So here we go with the drill. So I'm starting with a 2.2 millimeter width, but see, the shoulder stops it. So I don't have to think about the depth anymore. Now, the other thing I like about this technique is because I'm not reflecting a flap, I don't have to suture the flap, and I don't have to judge how thick the gingival tissue is. I'm saying the gingival tissue is 2 millimeters, and so I'm going to use, if I'm using a 14 millimeter drill, then I know my implant is going to be 12 millimeters. I subtract 2 millimeters for the tissue. The tissue is going to stop the drill, and if it's 14 millimeters, then the implant in the bone is going to be 12 millimeters. So here we go. This is the 2.2. Then I'm going to go to 2.8, and I'll usually take a radiograph either every drill or every 2 drills. Then I'm going to go to 3.7. You can see it's good and parallel. Then I'll go to 4.1. So it's very easy once you get your depth, because that shoulder is stopping on the soft tissue. So this is 2 millimeters. So if this is 14, you know you're going to have 12 millimeters in bone. And see, there's the tip of the root. So I'm not worried about the inferior alveolar nerve because it's apical to the tip of the root. There's the mental foramen on the second bicuspid. So I'm in good shape, and it's parallel to the adjacent teeth. Perfect is my favorite word. You don't get it perfect, but you're trying to. So this is good and parallel to the adjacent teeth. I've got plenty of room between the tip of the drill and the inferior alveolar nerve. It's the osteotomy. Here comes the implant. This is a 12 millimeter implant, 4x6. So the final drill was 4.3 millimeters in diameter. You want the implant to be a little bit wider than your osteotomy. So if you've got a 4.3, 4.2, 4.3 millimeter width of drill, you want an implant that's probably 4.6, 4.7. Okay, so I'm screwing this 12 millimeter implant to place, and I want to torque it to at least 35 Newton centimeters. Now, I'd like the coronal part of the implant to be just about at the alveolar crest. And remember, there's 2 millimeters of gingival tissue coronal to the crest of the implant. Then I'm going to place this longer healing cap. See, this is going to form an emergence profile around that longer healing cap. We take care of this cavity before we get to the end. So here's the implant. So see, we're about 12 millimeters, plenty of bone. Here's the inferior alveolar nerve down here, not close to that. No, you can see the nerve right there. There's the inferior alveolar nerve. So that's a good, safe distance from the nerve. The implant's nice and parallel. And we'll leave the healing cap's in place, and it goes through the tissue, so you're going to form a nice emergent profile. If you reflected a flap and place the implant, you'd put a flat healing cap, so you'd have to go back in 3 months and take a core, and then it's just a lot more involved for you and the patient. This is, in my opinion, a lot simpler and very accurate. So 3 months later, the implant has osseointegrated. So I've not anesthetized the patient. I'm unscrewing the healing cap. You can look how good that emergence profile looks. We've got good clear margins because we've had that healing cap on for 3 months. Then I love this. This is the BioHorizons impression coping and implant system. So this just snaps into place, and then try the tray in. This is a polyether with a custom tray. Very important you use a custom tray with polyether. If there's any question about the seating of the impression coping, take a radiograph, but you can feel it just snap into place, and then it's stable. If it hadn't snapped into place, you'll be able to move it. You know, it's very accurate. This is Blockout Luxabite, because that polyether is pretty rigid and you don't want it to lock into any undercuts. So here's the implant, Blockout around the rest of the teeth. Custom tray, very important. Then we squirt body material into the custom tray. Watch that link. Then we're going to put the wash material on top of that. Then I'm going to squirt wash material around the implant on both the facial and the lingual or the palatal sides. That I want to capture the gingival tissue. Leave this for 5 minutes. You see how accurate that is. Then I'm going to screw the impression coping back in, and the patient's not been anesthetized for any of this, unless they were just really gingivally sensitive, and it gives you feel a little bit of pressure in the gingival tissue, but there shouldn't be anything of consequence. And so then we'll take a shade, send it to the lab, then here's the crown. That's the Dental Minute. These techniques work, and they work every time.
Are you ready to take your dentistry practice to the highest level possible? Of course you are! Subscribe right now to dentistrymasterclasses.com, where you will get Dr. Cutbirth's greatest work and best cases. Here's what you're going to get when you subscribe to dentistrymasterclasses.com. Incredible comprehensive cases not seen in Dental Minute videos. You will get an organized library of all the Dental Minute videos and Dentistry Masterclasses, comprehensive cases for study and reference, before and after photos of Dr. Cutbirth's fantastic restored cases. And all of this, I repeat, all of this is just $40 a month. This is something you cannot pass up. Subscribe right now to dentistrymasterclasses.com.